So today we will discuss cardiomyopathies.
opening the exit pathway to the blood and completely relieving the dynamic obstruction.
It is extraordinary use to control toxic injury to restore functional anatomy. We are using a deadly poison to kill a highly specific part of the organ, all to save the overall function of the pump.
It's an elegant solution, really.
I want to put a huge pin in that concept of alcohol as a medical tool because we're absolutely going to circle back to it. But right now, we need to transition.
Yep.
We've explored the overstretched, flappy, elastic band of DCM. We've dissected the overgrown, chaotic bodybuilder muscle of HCM. But there is another condition in clinical outline where the muscle doesn't just stretch, it doesn't just grow. It undergoes a complete cellular identity crisis.
We are moving to arrhythmogenic right ventricular cardiomyopathy, or ARVC. And from a pathological standpoint, this is a profoundly strange and disturbing disease.
Tell me about it.
In ARVC, patches of the right ventricular myocardium, the actual force-generating heart muscle cells, systematically die off, and they are not replaced by scar tissue alone. They are replaced by a mixture of fibrous tissue and massive amounts of adipose tissue.
Adipose tissue. So fat, it literally turns from functioning muscle into inert fat. The heart is replacing its own engine parts with flutter.
That's one way to put it, yeah.
But looking at the geometry of this, I have a major question. We've spent this entire deep dive talking exclusively about the left ventricle. The left ventricle stretching, the left ventricle thickening, the left side has the immense pressure pumping to the whole body. Why does this specific disease target the low pressure right side of the heart?
It's an excellent biomechanical question. The right ventricle is inherently architecturally different from the left because it only has to pump blood right next door into the lungs against very low pulmonary vascular pressure. Its walls are naturally much thinner. Now, ARVC is an autosomal dominant genetic trait with a prevalence of about 10 per 100,000. The specific genetic mutations driving this disease target the desmosomes. Yes, think of desmosomes as heavy-duty microscopic ribbons. They are protein complexes that weld neighboring heart muscle cells tightly together, allowing them to withstand the constant mechanical stress of stretching and contracting.
So they hold the structure together.
Exactly. For reasons that are still the subject of intense cardiological research, these mutated, faulty rivets seem particularly vulnerable in the specific wall architecture of the right ventricle.
So under the constant mechanical stress of life and heartbeats, these faulty rivets just give way.
Exactly. The cells detach from one another. This detachment triggers cell death apoptosis. And the body's aberrant repair mechanism for this specific genetic flaw isn't just to lay down collagen, but to fill the resulting voids with fibrofatty tissue. The muscle is progressively cannibalized and replaced by fat.
And the clinical fallout from having a right ventricle composed of fat instead of muscle. I mean, it can't be good for the plumbing or the electrical grid.
It is devastating on both fronts. The text highlights 3 dominant clinical presentations. First, you see right-sided cardiac failure because the thin right ventricle is losing its contractile muscle mass to fat. The pump weakens.
Blood backs up again.
Blood backs up into the venous, causing severe swelling in the liver, the abdomen, and the lower extremity.
But the plumbing issue isn't the most immediate threat.
No, the most immediate threat is electrical. The healthy electrical signals of the heart, the wave fronts that coordinate the heartbeat, are designed to travel rapidly and smoothly through dense muscle tissue. Yes. When those electrical waves suddenly hit a fast patch of inert fat or dense fibrous tissue, the signal can't. It travels slowly around the pores of the fat, creating chaotic electrical reentry.
It's essentially an electrical short circuit caused by a structural pothole of fat.
That's a great visual.
And that leads to the second and third clinical problems highlighted in the text: devastating ventricular arrhythmias and sudden cardiac death. Much like HCM, the architecture of the tissue itself becomes a lethal electrical trap. So how on earth do you diagnose a heart that is slowly turning to fat before that short circuit happens?
The primary diagnostic clues are found on the 12 lead ECG. The text points to very specific electrical signatures. You look for a slightly broadened QRS complex, which indicates that the electrical signal is taking longer than normal to travel through the damaged right ventricle.
Okay, so delayed signal.
And inverted T waves, specifically in the right precordial, leads the leads placed physically over the right side of the chest.
So the electrical map shows the application of the fat pockets.
But because this is an autosomal dominant genetic condition, the burden of diagnosis extends far beyond the individual patient sitting in the clinic. The cardiac magnetic resonance imaging, or MRI.
Because MRI is fantastic at differentiating between different tissue densities, like muscle versus fat.
Precisely. An MRI can actually visualize that fibrin fatty replacement in the thin right ventricular wall. And for those patients diagnosed at high risk of sudden death, the primary defense is, once again, the surgical implantation of an ICD to shock the heart out of those patients.
It's an incredibly heavy psychological burden for a family to carry, knowing that genetic trait is passing down, silently replacing muscle with fat. It really reinforces the theme that these cardiomyopathies aren't just isolated random events. They're inherited architectural blueprints that dictate the lifespan of the organ.
It's a family disease.
Now let's move to the fourth major category of our clinical exploration. We've gone from a heart that's stretched and flabby, one that is massively thickened, to one that is turning to fat. Now we arrive at a heart that simply turns to stone.
Right.
We're looking at ventricles that become fundamentally, rigidly stiff.
We are categorizing restrictive and obliterative cardiomyopathy. The defining physiological feature of restrictive cardiomyopathy is a profound impairment of ventricular filling. The ventricles lose entirely their elasticity. They become extraordinarily stiff and non-compliant.
I picture it as a rigid iron cage. The muscle might not be massive like HCM, but it absolutely refuses.
A rigid cage is an excellent biomechanical metaphor. And if you think about the fluid dynamics of a rigid cage, the consequences are severe. During diastole, the ventricles are supposed to relax and expand to suck blood in from the atria and the upper chambers.
But if they can't expand,
If the main pumping chambers are too stiff to accept the blood has nowhere to go. It backs up.
it hits a brick wall.
It does. This backlog leads to abnormally high pressure within the atria. The thin-walled atria are subjected to extreme retrograde pressure. They are forced to dilate and hypertrophy in a desperate attempt to handle the volume of the blood.
And we know earlier that stretched atria are bad news.
Very bad news. As we mentioned earlier with DCM, severely stretched atrial tissue is highly arrhythmogenic. It is highly prone to electrical chaos, specifically atrial fibrillation, which the text highlights as a major, nearly inevitable consequence of restrictive disease.
So you have blood backing up, atria ballooning out, and fibrillating, all because the lower chambers won't budge. But what is actually making the walls stiff? Is it similar to the overgrown chaotic muscle we saw in HCM?
No, the pathophysiological mechanism is entirely different. It's rarely a problem of the muscle cells themselves growing too large. Rather, it is a problem of infiltration. Something abnormal, some foreign substance, depositing itself inside the interstitial spaces of the heart muscle tissue, physically restricting its movement.
What kind of infiltrates are we talking about? Like what's getting in there?
The text points out that amyloidosis is the most common cause. Amyloidosis is a systemic disease where the body produces abnormal misfolded proteins called amyloid fibrils.
Misfolded protein.
Yes. These proteins circulate in the blood and eventually precipitate out, depositing themselves in the extracellular spaces of various organs. When they deposit in the myocardium, they physically push the myocytes apart and keep them in rigid, insoluble lattice.
Like locking them down.
Imagine pouring microscopic grains of concrete into the intricate gears of an engine. It just gunks everything up and locks the mechanism in place.
The muscle cells might be perfectly healthy, but they are encased in a straitjacket of misfolded protein. That's wild.
Exactly. Other causes mentioned in the text include glycogen storage diseases, where metabolic errors cause complex sugars to build up aggressively within the cell between the regions, or idiopathic keratomyocyte fibrosis, which is an unexplained severe scarring that wraps directly around the individual muscle cell.
And diagnosing this sounds like an absolute nightmare, because from the outside, on a basic x-ray or even standard ultrasound, the heart might actually look relatively normal in overall size. It has ballooned out like DCM.
It is exceptionally difficult to differentiate from other restrictive processes like constrictive pericarditis, where the sac around the heart becomes stiff. Diagnosis requires complex, high-resolution Doppler echocardiography to measure the precise speed, timing, and flow patterns of blood as it attempts to enter the stiff ventricle.
So looking at how the blood flows, not just the muscle.
Yes. It requires advanced CT or MRI scans to look for the signature textures of infiltration. And often, a definitive diagnosis requires an endomyocardial biopsy. They literally have to make a catheter into the heart, a tiny pair of microscopic jars, and bite off a piece of the inner heart wall.
Wow. They physically take a chunk out.
Yes. They take that tissue sample to the pathology lab, stain it often with Congo red stain for amyloid
really sounds like a biological horror movie for your cardiovascular system. Obliterative cardiomyopathy.
Yes, this is a very rare, incredibly aggressive, and highly lethal form of restrictive disease. It specifically involves the endocardium, which is the innermost lining of one or both ventricles.
The text describes it as being characterized by massive thrombosis, which is widespread blood clotting and dense fibrosis, leading to the gradual obliteration of ventricular cavities.
It literally fills the chamber.
I want to build on that water pump analogy. If the heart is a mechanical water pump, obliterative cardiomyopathy is like someone slowly, deliberately pouring slow-spinning concrete directly into the pumping chamber. The internal space literally fills in from the bottom up with dense clots and impenetrable scar tissue until there is simply no physical room left for blood to enter. It obliterates the cavity.
The functional consequences of filling your heart with concrete are as severe as you can imagine. As the dense fibrotic mass grows inside the chamber, it physically engulfs the papillary muscles and the chording tendon, the internal parachute strings that hold the heart valve.
Oh, so it grabs the valves too.
The massive scarring pulls relentlessly on the valve, tethering them open and making the mitral and tricuspid valves profoundly regurgitated.
The chamber's actually to nothing, and the valves are glued open.
You see profound, intractable heart failure. And because the internal chambers are lined with highly active thrombogenic clots, the patient is at a massive risk for pulmonary and systemic embolism.
The clots break off.
Pieces of those clots are constantly at risk of breaking off and traveling to the lungs, causing pulmonary embolisms, or traveling up to carotid arteries in the brain, causing massive stroke.
And looking at the epidemiological data, the demographics and geography of this specific disease are highly unusual, right?
They are very specific. The text notes it can sometimes be associated with eosinophilia, which is an abnormally high level of a specific type of white blood cell seen in conditions like eosinophilic leukemia or Church-Strauss syndrome.
What do the white blood cells do?
The toxic granules released by these excess eosinophils directly damage the endocardial lining, triggering the massive clotting and scarring response. But geographically, the incidence spikes dramatically in tropical countries.
Really?
Yes, in regions like equatorial Africa, it is known as endomyocardial fibroelactosis, and it can be responsible for up to 10% of all cardiac deaths in those areas.
10% of cardiac deaths in an entire geographical region from this specific concrete in the pump disease. That is a staggering statistic. And the prognosis, as outlined in the text, is just devastating.
A 50% mortality rate at 2 years from symptom onset. The medical treatments attempt to manage the sheer chaos. They use heavy anticoagulation and antiplatelet therapy to try and stop the active clotting, and aggressive diuretics for the heart failure fluid backup. And in highly selected, desperate cases, there's a radical surgical option.
Decortication of the endocardium. What does that actually mean in plain English?
It means surgeons open the heart and literally attempt to peel, scrape, or carve a thick concrete-like layer of scar tissue and organized clot out of the inside of the ventricle, hoping to restore some internal volume.
Just mechanically scraping it out.
Yes, and they almost always have to replace the ruined tethered valves with mechanical prosthetics at the same time.
It is a profound testament to the extremes that modern cardiothoracic surgery will go to fight these structural failures. But as we move into the final analytical section of our deep dive, the clinical text throws a massive curveball into the diagnostic process.
It really does.
Because the heart doesn't always break down on its own due to internal genetic blueprints or isolated structural flaws. Sometimes there are outside invaders. Systemic diseases that attack the heart and perfectly mimic the primary cardiomyopathies we just spent the last 45 minutes dissecting.
This is a vital distinction in real-world clinical practice. Box 18.127 from our source text is an extensive table entirely dedicated to specific diseases of heart muscle. These are secondary cardiomyopathy.
So the heart is just collateral damage.
Exactly. Structural failure of the heart, the dilatation, hypertrophy, the restriction is just one localized symptom of a much larger systemic war happening throughout the patient's entire body.
The text breaks these invaders down category by systemic category. And rather than just reading a list of 30 diseases, let's look at the mechanism of a few of these to understand how a disease that starts somewhere else completely remodels the architecture of the heart.
Sure, let's take a look.
For example, under the infections category, text lists Borrelia burgdorferi.
That is the spirochete bacterium that causes Lyme disease.
A tick bite. I mean, you get bit by a tick in the woods and suddenly you have a failing heart. How does a tick bite mimic dilated cardiomyopathy?
It's a remarkable pathogenesis. When the Borrelia bacteria enter the bloodstream, they can disseminate to multiple organs, including the myocardium. This is known as Lyme carditis. The bacteria physically invade the interstitial tissue of the heart. The body mounts a massive inflammatory response, sending macrophages to destroy the bacteria. This severe acute inflammation heavily damages the myocardial fibers, causing them to weaken and stretch.
So it causes dilatation.
It does. Furthermore, the inflammation specifically targets the heart's electrical conduction system, often causing high-degree atrioventricular block. The electrical signal from the top of the heart gets completely blocked from reaching the bottom.
So the heart dilates, becomes flabby, and electrically short circuits, perfectly mimicking primary DCM, all from a bacterial infection. That is incredible.
It's a perfect mimic.
And what about the infiltrative disorders? We discussed amyloidosis mimicking a restrictive, rigid heart, but the text also lists hemochromatosis.
Hemochromatosis is a genetic disorder of iron metabolism. The body simply absorbs too much dietary iron from the gut and has no physiological mechanism to excrete the excess.
So it just builds up.
Over decades, this free iron builds up to toxic levels in the blood, and the body begins dumping it into various organs for storage: the liver, the pancreas, and critically, the myocardium.
So instead of misfolded proteins like an amyloidosis, the heart is literally filling up with rust.
Essentially, yes. Iron deposition in the myocytes creates massive oxidative stress. It damages the cellular machinery and triggers extensive interstitial fibrosis. The heart becomes incredibly stiff and heavy, leading to a classic restrictive cardiomyopathy presentation, eventually progressing to a dilated phalanx.
And then there are the neuromuscular disorders. The text specifically calls out Friedreich's ataxia.
Friedreich's ataxia is a rare inherited disease that causes progressive damage to the nervous system, leading to muscle weakness, speech problems, and a loss of coordination ataxia. But the text notes a highly specific cardiac manifestation. It profoundly mimics hypertrophic cardiomyopathy. The genetic mutation in Friedreich's ataxia affects a mitochondrial protein called frataxin, which leads to severe energy deficiency and iron accumulation within the mitochondria.
So a mitochondrial crisis.
Yes, and for complex reasons, the heart's response to this specific mitochondrial crisis is to undergo massive concentric hypertrophy. The walls become incredibly thick, exactly like the genetic HCM we discussed earlier, even though the primary disease is a neurological disorder.
So what does this all mean? If you were a clinician and a patient presents with a dilated, flabby, failing heart, how can you possibly tell the difference between a primary inherited genetic failure and a heart that is just collateral damage from a tick bite or iron overload, or a thyroid disorder like hyperthyroidism, which forces the heart to beat itself to death?
This raises an important question, and it really brings us to the core philosophy of modern internal medicine. It emphasizes why a cardiologist can never look at an organ in total isolation.
You can't just fixate on the pump.
You cannot just look at an echocardiogram, see a stretched ventricle, and confidently declare, primary dilated cardiomyopathy. Take these beta blockers and let's discuss the transplant. The clinician must act as a systemic detective.
They have to look at everything.
They have to order iron panels, check thyroid stimulating hormone levels, run autoimmune antibody panels, and take a meticulous patient history.
Because, as the text concludes regarding these specific diseases of the heart muscle, the treatment and prognosis are entirely determined by treating the underlying systemic disorder. You have to treat the root cause, not just the architecturals.
Precisely. If the heart is failing and dilating because of Lyme carditis, you don't need a heart transplant, and you don't necessarily need lifelong heart failure medication. You need a prolonged course of heavy intravenous antibiotics like ceftriaxone to eradicate the Borrelia bacteria.
And if you kill the bacteria,
if you kill the invader, the inflammation subsides and the heart often recovers completely. If the heart is stiffening due to hemochromatosis, the treatment isn't a complex cardiac surgery, it's therapeutic phlebotomy.
Bloodletting, basically.
You routinely draw blood from the patient to force the body to deplete its iron stores to make new red blood cells, literally draining the toxic iron out of the myocardial tissue over time.
And this brings us to perhaps the most hopeful redemptive note in the entire clinical text, specifically regarding the toxins category. We mentioned earlier that heavy alcohol consumption is a profound cardiotoxin that directly causes dilated cardiomyopathy.
Yes, alcoholic cardiomyopathy.
But the text explicitly states abstention from alcohol may lead to a dramatic improvement in patients with alcoholic heart muscle disease.
It is a phenomenal clinical observation. Unlike a sarcomere genetic mutation that is hardwired into your DNA, or the massive, irreversible concrete scarring of obliterative disease, alcoholic cardiomyopathy represents a scenario of incredible physiological resilience.
So the heart can bounce back.
The ethanol metabolates directly poison the mitochondria and suppress the contractile protein. But if you remove the toxic insult, if the patient achieves total abstinence, the myocytes can regenerate their internal machinery. The myocardium possesses an astonishing capacity to heal, to regain its contractile force, and to actually reverse the massive dilatation, shrinking back to a normal size and function.
It is the ultimate proof of how forgiving the human architecture can be if you just stop systematically poisoning it. Which brings us to the conclusion of our analysis today. We set out with a mission to translate this dense, highly technical clinical document into a real functional understanding of how the human heart physically fails for you. And I think what is abundantly clear is that heart disease or heart failure isn't just one monolithic uniform event.
It is a wildly diverse array of structural, geometric, and architectural collapses. I mean, we've explored the overstretched, exhausted, elastic bands of dilated cardiomyopathy where the pump becomes too flabby to push. We've examined the dangerously overgrown, chaotic bodybuilder muscle of hypertrophic cardiomyopathy, where the muscle becomes so massive it suffocates its own exit.
We've seen the bizarre identity crisis of genic right ventricular cardiomyopathy, where vital muscle quietly turns to fat, creating deadly electrical short circuits. And we've looked at the terrifying, unyielding reality of restrictive and obliterative diseases, where the heart becomes a rigid iron cage, infiltrated by misfolded proteins or slowly filled from the bottom up with biological concrete.
Understanding these incredible macroscopic and microscopic nuances, the actual physical geometry of the cellular failure is the only way the medical establishment can develop the precise, highly targeted, and frankly, sometimes shockingly counterintuitive treatments.
Which brings